All right. So the primary objective of this talk, it's going to be a 20-minute session, is going to be to review the role of radiation oncology in the multidisciplinary management of prostate cancer. Hopefully this will complement Mac's talk in terms of setting the stage for what we do today and hit upon some of the current topics and controversies that we discuss in the States. Just for brief background, we're going to talk about risk classification and PSA screening briefly and focus most of the time on going over treatment guidelines for the use of radiation for intact prostate cancer and for postoperative prostate cancer. So the first order of business is to identify the appropriate risk classification scheme. Risk classification is essential because of the wide variance in outcome for men who have low or high risk prostate cancer. The NCCN system is one of the most commonly used. It stratifies risk according to three important clinical criteria: T-stage, which is appreciated on digital rectal exam; Gleason score, which is the grade of cancer, which is identified on biopsy; and PSA, which is a serum biomarker. So a man with low-risk prostate cancer is identified as someone who has T1 to T2A disease and Gleason score 6 or lower and PSA less than 10. A man with high-risk prostate cancer has extracapsular extension on clinical exam, or T3A, or Gleason score 8 or higher, or PSA that's greater than 20. Intermediate risk is everyone in between that. Now, in the US, most of what we see is low or intermediate risk disease, and for those patients, we end up having to consider surveillance as an important priority because of the long natural history of progression, even without treatment. This is because PSA screening is very commonly done in the US. This means men are getting annual PSAs from the age of 50, maybe to 75 or so, depending on their life expectancy. As I understand here at KCMC, PSA screening is not commonly done because of the expense, and as a result, men are being diagnosed with high, very high, or metastatic disease. Now, the subject of PSA screening is actually quite controversial right now in the United States. This is because prostate cancer treatment comes with a lot of risks, it's very expensive, and it's actually not certain whether most men in the US are going to die of their disease, especially if they have low or intermediate risk only disease. So the US government ended up putting up a task force to study the issues and review all of the literature. So in 2012, this was conducted and reported. The USPSTF ended up looking at the literature and assigning a grade D recommendation, which is a poor score, which means that PSA screening could actually do more harm than good. So they report here there's a very small potential benefit and significant potential harm. We encourage clinicians to consider this evidence and not screen their patients with a PSA test unless the individual being screened understands what's known about PSA screening and makes the personal decision that even a small possibility of benefit outweighs the known risks of harm. So, in looking at the data, it would be most ideal to look at randomized trials that puts men on screening versus no screening and make a decision based on that. We have two such major randomized studies that have been done, and these aren't necessarily ideal trials. One of them was conducted in the US, the PLCO trial. This enrolled 76,000 plus men between the ages of 55 and 74 to get PSA screening every year for 6 years versus usual care. With a follow-up of 13 years, this study showed no benefit for prostate cancer-specific mortality. Now, one of the limitations in this study is that there was significant contamination in the usual care arm. It's just so common in the US for men to get PSAs, and even the ones that were put on this study who weren't necessarily intended to get screened did get screened, and that may have diminished some of the impact, the positive impact that screening could have shown. Now, the ERSPC trial was done in Europe. It was larger, 182,000 men. It randomized men between the ages of 50 and 74 to PSAs every 2 to 4 years versus usual care. And this was a cleaner study where in Europe, PSA screening is not so common, so the usual care arm did not have this contamination. With a follow-up of 11 years, there is a reduction of prostate cancer-specific mortality and metastasis. However, the number needed to screen and the number needed to treat look quite high. So, how convincing does it sound if you have to screen 1,055 men in order to avert one cancer death or treat 37 men and have them all incur risks of therapy? Is that convincing? And the USPSTF looked at this information and felt that it wasn't necessarily convincing. So now everyone has their own opinion about PSA screening. My feeling is that perhaps screening per se is not the problem, but rather it's a challenge. It's the challenge to stratify and select only appropriate men for therapy. So what I mean by that is I think screening probably does help to save lives. We know that. It may take a lot of men. And the risks that are incurred are probably a result of overtreating men who are not at a high risk of dying from their disease. So as physicians, I think we'd like to have that information and know who has the cancer, but just be judicious about how we apply our therapy so that it's selective for the appropriate patients. Now we're going to go through each of the risk categories and go over the current paradigm of management in the US. So treatment option menus for men who have low-risk disease include the following: radical prostatectomy, radiation therapy, and active surveillance. So the first two are both local therapies, so surgery versus radiation. This is a classic debate that we sometimes have in our tumor boards. There isn't necessarily one right answer about whether a man needs surgery or radiation. There might be occasional clinical circumstances where one is obviously better than another, but in most cases we end up having discussions where patients will come and see a surgeon and then a radiation oncologist, hopefully around the same time, hear about the benefits and the risks of each of them, and make a decision. And I think a lot of the decisions that are made are based on referral patterns and also based on patient preferences about what side effects they want to take a risk of incurring. Now, radiation therapy comes in two flavors. There's brachytherapy and external beam. We've heard already a lot about brachytherapy. It's implantation of radioactive sources. You can do this for the prostate with an HDR unit or with an LDR approach where permanent radioactive seeds are implanted. The external beam radiation approach is typically done over 8 weeks of time using standard fractionation. We heard about whether we need to use IMRT or 3D conformal, and I think either would be acceptable. You just have to try to meet good sparing goals to try to keep it safe. There's also an issue of external beam radiation of using standard fractionation or hypofractionation. We'll get a little bit more into that, but basically the thinking is that an 8-week course of radiation therapy could be just as effective as a 5-week or even shorter course of therapy, and this is an area of interest right now. Now, active surveillance is something that's of growing interest and importance for men with low-risk disease. What this means is a man who's diagnosed with a low-risk problem who might not have a problem with prostate cancer, even if untreated, for another 15 or 20 years, who's at risk of dying of something else, is better off by just surveilling that cancer without incurring any risks of local therapy. So the standard protocol that we follow is a patient will come back regularly every 3 to 6 months, have clinical exams with a digital rectal exam, a PSA, and then have frequent biopsies, maybe every year, at least in the beginning, and maybe stretching out to every 2 to 4 years thereafter. Then there would be predefined limits as to where, if there's progression and you're worried about the cancer changing and becoming more aggressive, having a higher risk of metastatic progression, then you would intervene and then treat with a local therapy. So the outcomes for surgery and radiation for low-risk disease are actually quite good. Initially, we might have considered this as one of the success stories of radiation therapy and surgery for a common cancer. So we now have long-term follow-up of men treated for low-risk prostate cancer. A large series from 5 centers reported that there's a 1% risk of cancer death at 15 to 20 years for Gleason score 6 disease treated with surgery. And meanwhile, another study from British Columbia showed that in 1,000 men treated with brachytherapy only for low-risk disease, there's only a 1% risk of cancer death. So these are very good outcomes, and they look very encouraging. External beam radiation shows a similar story nowadays because of a lot of randomized studies that test dose-escalated radiation versus more conventional doses of radiation, showing a benefit of PSA survival. Dose-escalated radiation is now considered a standard of care. And in this series from New York City, Memorial Sloan Kettering, there is a 10% risk of PSA recurrence, but none of these men end up dying of their cancer at 8 years out. Now, we talked about how hypofractionation is a growing area of interest. This is in large part, I think, because of a resource issue. So in the States, we're struggling a bit with cost containment. IMRT, which is standard for radiation therapy for the prostate, is quite expensive. The Medicare reimbursement's more than $15,000. So, and because radiation therapy is reimbursed on a per-day fraction, I think we all have an interest to try to keep our healthcare model sustainable, and I think we're going to be encouraged by the government in time to get shorter and shorter with our treatments as long as it's just as effective and just as safe. So there are a number of different fraction schedules that seem to have a similar biological equivalent dose, ranging from 78 gray at 2 gray per fraction, which is 39 days of treatment, versus 36.25 gray at 7.25 gray per fraction, which is only 5 days. So now looking at the collective data for implants, radiation, external beam, having a 0 to 1% risk of cancer death really makes you wonder how much we're over-treating this cancer, if it's killing so few people. And it makes you also wonder whether this over-treatment is really impairing people's quality of life when they may not actually need treatment at all. So to speak to that point, there are some series now that are maturing with longer follow-up, showing pretty encouraging results with doing active surveillance. You can see in the red box here, the disease-specific survival is actually 97 to 100%, anywhere from 2 to 10 years out. So this is actually the same as if you were to have treatment. So now, it doesn't mean that people don't require treatment. It just means you're following them, you're taking the people who progress more rapidly, then treating them with a local therapy, and then hopefully seeing that you're not having any detriment in the overall cancer cure rate. Now, the future of low-risk disease is probably, it's an important issue because PSA screening is under fire. We're not sure which men we really need to treat, and I think part of the problem is we need to identify men in the low-risk category who may have occult higher-risk disease and then treat those patients. And the men who really truly have indolent low-risk disease could just be observed. It's interesting to remember that men who have autopsies at the age of 70 have about a 60% chance of having prostate cancer. So a lot of these men may just have incidentally found cancers because of a PSA of 3, which is not very high. Now, two areas of interest that may help us with this issue to further stratify who we need to treat or not are shown here on this slide. So imagine when a man has a biopsy. He has a transrectal ultrasound put into the rectum, and blind biopsies are punched into the back part of the prostate, into the peripheral zone. Usually there's 12 cores. Now, this is not a directed biopsy. You can't actually see cancers well on ultrasound. But what if we were to do an MRI and be able to see a dominant nodule and put a needle specifically into that area with MRI guidance? So some studies have already been published on this approach and have shown that about 1/3 of the time you end up upgrading the cancer from low risk. So this is an interesting area, still under evaluation and not standard of care, but maybe it'll help us better select men for active surveillance versus treatment. Similarly, genomic prostate scores have been defined using RNA expression. It's basically dissecting out tumors from slides and then doing some RNA analysis of several different genes and showing whether they have a higher tendency to fail or not. So there is such a test available. It's expensive, not necessarily covered by insurance, but this type of score can help us know which cancers are more likely to fail and need treatments. Now moving on to the intermediate risk category. So treatment options actually don't look that different from low risk, but you'll notice active surveillance is not on the menu. It is still appropriate for select cases of men who have a shorter life expectancy, but more often than not, for a younger guy who has an intermediate risk tumor, we're going to treat that with local therapy. And radical prostatectomy and radiation are both viable options. The menu for radiation therapy is a little bit different for low risk. You'll see that brachytherapy and external beam are still on here, but there's an addition of considering short course hormonal therapy or a brachytherapy boost. Now the brachytherapy boost is basically a reduced intensity implant that you would use to follow an abbreviated course of external beam, such that you could give external beam to an area that you think is at subclinical risk, prostate and seminal vesicles typically, and then come in and boost the prostate with an implant to get an overall higher effective dose. A short course hormonal therapy for intermediate risk disease is well established with many randomized studies, and this is just one of them. I selected at random. The RTOG 9408 randomized about 2,000 patients to get 66.6 gray, plus or minus 4 months of dual agent hormonal therapy in the form of anti-androgen and LHRH agonist. With a long median follow-up of 9 years, the men who had hormonal therapy had an improved survival, had a lower chance of having prostate cancer-specific mortality by about half, and also had a higher rate of biopsy clearance. So having a biopsy 2 years after the radiation's done, men who had hormonal therapy were half as likely to have residual cancer. So why does this happen? It's because hormonal therapy acts as a sensitizer to radiation. And for men in the higher risk category of intermediate risk, we have more of a reliance on trying to clear the disease with additive therapy. Now, men in the high-risk category are treated with radical prostatectomy for only select cases and radiation therapy. Now, Surgeons traditionally would shy away from taking these cases because they'd be worried about leaving positive margins. And we'll talk about later on about how radiation is usually used to follow. So men in this category, if surgeons are not really confident that they can get all of the disease out, traditionally they used to shy away and refer them for radiation and hormonal therapy. But in the US, at least at my institution, there's been sort of a trend for surgeons to come into this high-risk space, maybe in part to try to fill their caseload, which is going away from active surveillance, or maybe because of increased confidence that with new techniques and using a robotic approach that they can get clearer margins and better long-term outcomes. Now, radiation therapy is a standard of care in this setting, but one of the differences from intermediate risk is that no longer are we recommending short-course hormonal therapy, we're recommending long-course hormonal therapy. And the point of this is to try to act as a sensitizer and improve local control, but also to try to reduce the risk of distant metastases. So, primary hormonal therapy is something that actually is commonly done, but it isn't really well established with data that that's a good approach. So, I spoke with Dr. Ken Mehta here at KCMC, and he had said that a lot of men who are diagnosed are in the high risk or the metastatic category. They get treated with primary hormonal therapy just because of the lack of ability to send patients to DAR for radiation, and the advanced presentation makes them unfavorable candidates for radical prostatectomy. So this is an approach that we do try to temper and limit in the US because hormonal therapy alone is thought to be only a palliative maneuver. The PSA will come down, it may stay down for some time, but eventually the disease will grow and become castrate resistant. And overall, it tends to be the case that survival is not impacted. Now, the role of radiation is well established in the high-risk setting based on some randomized studies. So there are two major ones that come from Scandinavia and Canada and the MRC. They take men who have high-risk disease defined by a T3 exam, which is extracapsular extension, and they randomize men to get conventional doses of radiation, 65 to 70 gray, and anti-androgen or LHRH agonists long-term. So half the men ended up getting radiation and hormone therapy, the other half ended up getting only hormonal therapy. Both of these studies were actually very positive for their primary endpoints. The SPCG7 showed a reduction in cause-specific mortality by about half. So at 10 years, the mortality from prostate cancer dropped from 24% to 12%. And in the NCIC MRC study, the overall survival went up by about 8–10% at an 7-year time point. So notice what happens to those men who have high-risk disease and they only get hormonal therapy. At 10 years, 75% of them are failing with their PSA and 24% are dying of their disease. On average, it'll take 6.8 years for the hormone therapy to stop working and then having men suffer from bony metastases and so on. So based on these two landmark studies, radiation is really entrenched in this high-risk category and should be added to hormonal therapy to try to improve survival. It can be done with limited side effects, limited severe side effects. And keep in mind that these trials were started many years ago. So in today's setting, at least in the US, there's probably a wider risk-benefit ratio with newer technology. And here in Tanzania, we shouldn't feel disappointed that we can't offer the highest technology because this was done in a setting of conventional therapy and still showed a pretty sizable improvement in survival. So the role of hormonal therapy with radiation is well established from many cooperative group randomized studies that were pretty large. So pretty much all of them that compared some amount of hormone therapy to none, so 36 months versus 0 months, indefinite versus none, 4 versus 0, or 0 versus 3 versus 6. These all showed benefits in the PSA control rates, the local control, the distant metastasis rates, and cause-specific survival, and many of them showed an overall survival advantage. Meanwhile, the comparison of long-course versus short-course hormone therapy also showed a benefit in 28 versus 4 months or 36 versus 6 months. A comparison that was done more recently compared 36 and 18 months and showed no differences. So this suggests that 18 months might be the minimum amount of long-term hormonal therapy to give with men with high-risk disease. They don't necessarily need long-term hormonal therapy or lifelong hormonal therapy. So this is kind of how we interpret the available information at University of Chicago. They're just guidelines, so don't take them too absolutely. There's definitely some leeway where you can tailor the treatment to the patient. But when a man is diagnosed with prostate cancer, the first step that we do is we assess them in the clinic. We try to make an estimation of their life expectancy. We look at the Social Security death indexes that's available from a government website. A 70-year-old man will live about 14 years, so we use that in our assessment along with the risk category of the prostate cancer to try to determine whether it makes sense to treat the patient or not. So we'll talk about treatment versus no treatment with the patient, then we'll talk about surgery versus radiation. And if we decide to treat them with radiation, then we follow this paradigm that assigns different treatments based on their risk category. So low-risk cancers would typically be treated with either external beam or brachytherapy. The external beam is 78 Gray at 2 per fraction, where we treat the prostate only without hormonal therapy. And brachytherapy would be given as monotherapy, meaning alone, without any combination of hormone therapy or external beam. We tend to prefer brachytherapy for patients who are younger just because if they live longer, then they're more at risk of having long-term issues with the PSA recurrence. Also, the PSA cure rates with brachytherapy seem to be a little bit more flat and the curves plateau better than with external beam, where they do tend to drop off a little bit with time. Now, intermediate risk disease is pretty heterogeneous. We try to use a clinical risk factor of % positive cores to try to stratify them into a favorable and an unfavorable risk. And the people in the unfavorable risk will add short course hormonal therapy for 6 months. And we'll time that 2 months before, 2 months during, and then 2 months after. In this group, if the men are young, we'll also consider doing a boost and following an initial course of external beam with a reduced dose implant dose. Now, men in high risk, this is probably of the greatest interest to the staff, local staff here, because this is probably the kind of patient that you'll see. Men in this side of the panel with T3 disease, high Gleason scores, high volume disease, or node-positive disease will end up including pelvic lymph nodes to an initial field and then boosting the prostate with external beam to a dose of 79.2 Gray. We'll do long-term hormonal therapy for 28 months. We'll also consider an implant boost for men who are the most fit with the longest life expectancy. And in rare circumstances, depending on their comorbidity, we may identify men in this high-risk category who are a little bit more favorable and consider doing less intensive therapy with shorter courses of hormonal therapy. Now, comorbidity can downstage treatment. I think one of the harder things about prostate cancer is that there really isn't a set cookie-cutter way to treat every patient. And it's very difficult as physicians to try to make accurate estimations of life expectancy and then also weigh that against the natural history of progression of cancer. So, to me, I think this makes prostate cancer management a little bit more challenging because you try to have to use your judgment to balance the benefits and the risks of any treatment that you're going to provide. So we'll move on to postoperative radiation therapy. So as we know, surgery is a common modality, a local therapy that we could give for low, intermediate, and sometimes high-risk disease. There are several surgical series that have been reported to try to identify which men are most likely to fail surgery. And you can see in this table of 3 studies, all of more than 1,000 patients with 10-year follow-up, that men who have positive margins, T3 disease, have about a 50 to 75% risk of failure at 10 years out, so not so good. So with that background in mind, there were several trials that were designed to try to test the hypothesis that giving radiation, even before a man fails, can help to reduce their risk of recurrence. That's considered adjuvant radiation. So these 3 studies took men with T3 or positive margins and randomized them to get adjuvant radiation therapy versus no specific follow-up care. And they gave 60 to 64 Gray to the prostate bed within 3 or 4 months of surgery. All of these 3 studies showed a reduction in the PSA failure rate at 10 years out by about half. And all of these were positive studies for their primary endpoint. So one of them showed an improvement in metastasis-free survival and overall survival as well. And the trade-off was actually pretty reasonable. There wasn't a high risk of severe late side effects from the radiation therapy. So in response to this, 2 national organizations in the US, the American Society of Radiation Oncology and the American Urologic Association, got together, reviewed all of the available literature, and put together some recommendations. So some of them regarding adjuvant radiation are to counsel men on the possibility of recurrence after radical prostatectomy and to inform men that adjuvant radiation therapy can be beneficial. They assigned grade A evidence, which is the highest level of evidence, regarding this recommendation to offer men with negative features at radical prostatectomy adjuvant radiation therapy. So that's men with positive margins or T3 disease. And the word choice is very careful. Offer means you consider it, you discuss with the patient, his family, and the multidisciplinary treatment team that should engage the patient in a shared decision-making process in which the patient's advised to consider the possibility of additional treatment. It doesn't actually come out stronger and say you must do this, and that's important to remember. If you look back at patterns of care, it's actually interesting to note that despite these recommendations and these big trials coming out, the rate of actually recommending adjuvant radiation therapy has not increased in the US. It's stayed steady at about 15%, according to SEER registry data. And there might be two major reasons for this, to explain this. One is that in these randomized studies, the observation group did not routinely receive early salvage radiation therapy after failure. So that means is, some of the men got adjuvant radiation, some of them had nothing. The men who had nothing, we worry that if they had had early treatment when their PSA started to go up after surgery, because after surgery your PSA should be 0, maybe that would have minimized that gap between the two groups. Because some people think early salvage radiation therapy may be just as good as adjuvant radiation therapy. Secondarily, a large percentage of men may be treated unnecessarily. This is a concern with any kind of adjuvant therapy where you're giving more treatments just to try to make sure the cancer doesn't come back. Some of those patients aren't destined to actually fail, and you're ending up accepting overtreatment in some percentage of patients. So trials are accruing to address this issue of whether or not we should give adjuvant or just sort of wait and see and jump in and do early salvage radiation treatment with a very low PSA only as needed. So salvage radiation therapy is moderately effective when you have a man who has a prostate removed and their PSA starts to creep up. It can help to make the PSA go back down. It depends on a lot of factors, including the grade of disease, the Gleason score, the PSA at the time, and stage, margin status, and how fast their PSA is going up. The notion is that if the PSA is still low and creeping up, then you could jump in and give radiation just to the local or regional bed and expect that that PSA hasn't gone further away such that the PSA recurrence is curable. PSA value, the level, is actually one of the most critical parameters to define whether treatment is successful. So a PSA of less than 0.5, for example, gives a 48% chance of cure, whereas a PSA that's more than 1.5 will limit that to 18% only. So in the US, we often do have men who end up getting surgery. Maybe the numbers of men in our institution who get surgery are even more than those who have radiation. We end up seeing them and trying to offer them radiation as soon as we can with a low PSA, assuming that they have a long life expectancy and appropriate risk factors. So the way we interpret the data for the post-op setting is we make that initial assessment similar to the intact setting where we're looking at their life expectancy and their comorbidity, considering treatment versus no treatment. We'll consider adjuvant therapy for appropriate men who have high risk factors for recurrence, give them 64 gray to the bed alone without hormone therapy in general. If they have node-positive disease, we end up including the pelvic lymph nodes in initial field and adding hormonal therapy. More commonly, however, we don't like the idea of overtreatment, and we tend to wait and see at our clinic what the PSA does. We tend to offer them salvage radiation therapy when the PSA is detectable, and we stratify them into two groups, favorable or unfavorable. The favorables get 68 gray to the prostate bed without hormonal therapy. The unfavorables get inclusion of their pelvic lymph nodes and hormonal therapy. Now, recurrent and metastatic disease is a common issue for patients who are probably seen here. In the US, if someone fails local therapy or presents with metastatic disease, the mainstay is to have hormonal treatment, either through surgical castration or medical castration. This will usually work for some number of months to years, depending on the biology of the cancer. Eventually, usually, it does recur, and the PSA will start to go up in spite of being on hormonal therapy.